altered ratio between E and A wafer, because, as you can see, the A ratio is the active ratio, active phase related to the atrial contraction. And the reason is, again, in the reduced performance of the atrial myocardium that produce this hemodynamic event. If we look to the venous district of the fetus, which is one of the most important in order to identify fetus in decompensating stage, we can see the ductus venosus. Here you can see on the left the normal waveform profile, the ductus arteriosus, the ductus venosus, sorry. And here you can see the situation, the waveform profile in this vessel in the decompensation stage. We can see a reduction of the forward flow and in appearance of the reverse flow during atrial contraction. You can see here is the normal waveform profile. And if we look to the waveform profile in this decompensating stage, we can see reduction in the forward flow and reverse flow during atrial contraction. That is related to the impaired function of the heart, of the myocardium. If we look to the inferior vena cava, we can see the same. You can see on the left the normal waveform profile with very high forward flow and very little reverse flow during atrial contraction. And here in the compensation stage, we can see a reduction in the forward flow and very high reverse flow during atrial contraction. And again, the waveform profile in this situation is related to the incipient heart failure and the hemodynamic event that are realizing in this condition in the right side of the heart, and particularly in the right atrium, that produce this alteration in both inferior vena cava and the ductus venosus. If we look to the umbilical vein, we can see a progressive deterioration characterized by the progressive alteration, hemodynamic alteration in this vessel. You can see here at the beginning, we have a good flow, forward flow in the umbilical vein with very little pulsation that are synchronous with the cardiac cycle, very different from this pulsation that are not synchronous with the cardiac cycle that are related to the fetal breathing. But look here, these pulsations are more evident than before, and with the evolution of the compensation in the fetus, we can see not only a very evident pulsation, but also a reduction in the forward flow in this vessel. And finally, you can see very close to the fetal death, there is almost no flow in the umbilical vein. Here you can see the scheme of this decompensation stage that are characterized by reverse diastolic flow in the umbilical artery and in the arterial district of the fetus, all alteration with the increased impedance to flow in all cardiac and venous district of the fetus. And here you can see in this situation are very evident the pathological profile in the CTG tracing in the fetus. So there is very evident alteration also in the biophysical profile. So here are the difference between the early onset IUGR and the late onset IUGR. The early onset IUGR, this typical cascade of the hemodynamic event I showed you in the previous slide. Now I'm going to show you the late onset IUGR. And you can see here some difference. The gestational age are more than 32 weeks of gestation. The maternal hypertension is present, but less frequent. Small fetus, normal morphology, etc. We may have a light reduction of the amniotic fluid or no reduction in the amniotic fluid, alteration in the placental perfusion that are generally not so evident or very late, and alteration in the umbilical arteries that generally are not so evident or very late. But we have, very important, the cerebral vasodilation that is very evident even at the beginning of this kind of scenario that characterizes the late onset. But very important, we generally have the absence of the typical cascade of hemodynamic changes that I showed you before for the early onset. But I want to tell you that it is very important to make the diagnosis of this challenging condition, because also these fetuses are at risk of oxygen deficiency and may have oxygen-related injuries in some organ systems, and particularly into the brain, and this scenario may produce also a fetal death in utero. So here are the difference in the hemodynamic changes and the time of the evolution of the changes in these two different IUGR. You can see here the early onset produced a very evident reduction in the amniotic fluid, generally is not so evident in the late onset. You can see the uterine hemodynamic are increased impedance to flow values very rapidly, the uterine artery and also the umbilical artery. Less evident, we have generally an increase in the umbilical artery, but with not so rapid evolution. You can see here the alteration in the ductus venosus and the uterine artery is not so evident, but we have an abnormal value in general in the mid-cerebral artery. So with the so-called cerebral placental ratio alterated or cerebral umbilical ratio alterated, which is one of the most important signs in this late onset IUGR. Only at the end of this scenario, when generally we can hypothesize that we have some sequelae and the compensation phase of the fetus, we may have the alteration in the umbilical artery, in the ductus venosus, and in the mid-cerebral artery, as we have seen in the previous scenarios characterizing the early onset IUGR. So here are the combination in the evolution in the hemodynamic event in the two different hemodynamic scenarios. So here you can see the difference between these two very challenging scenarios, the early and the late onset IUGR. If we look into the degree of the placenta disease, we can see that it's severe in the early onset and generally low in the early onset. We have maternal clinical signs that are severe in the early onset are mild or absent in the late onset. We have to keep in mind this aspect that is very important for the management of the fetus, with these two different type of IUGR. Generally, the fetal tolerance to oxygen deficiency is high in the early onset, but is low in late onset. So fetuses with late onset IUGR is more fragile than fetuses with early onset IUGR. The fetal oxygen deficiency is high in the early onset, may be low or mild in the late onset, but may produce also in the late onset some fetal sequelae. The fetal cardiovascular changes are very high and evident in the early onset, are absent or late in the late onset. So this situation is more challenging for the diagnosis than the early onset. But the sequelae you can see are the same. The problem in the early onset is the management, because the diagnosis is we can say that it's easy. In the late onset, the problem is the diagnosis, because we have an alternative in managing this kind of situation. And particularly, we can induce the maturation of the lungs in the fetus, and to take out the baby, the fetus, in this kind of challenging situation that can produce fetal sequelae. As I showed you before, we may have another possible scenario that I call it in my publication in the Journal of Maternal Fetal Neonatal Medicine some years ago, atypical IUGR, that is characterized by maternal LT condition with no hypertension, fetal a reduction in fetal growth, so small fetus, normal morphology, sometimes with very high reduction in amniotic fluid, normal impedance in the uteroplacental district, which is one of the most important aspects that characterize this atypical IUGR. And I'm going to show you there is an atypical fetal maternal hemodynamic pattern, completely different with the typical that I showed you before for the early onset IUGR. It is important, again, the diagnosis of this kind of situation, because these fetuses in this scenario may have sequelae or may death in utero for the hypoxic situation. You can see the meaning of atypical hemodynamic pattern. Atypical refers particularly to variable and instable fetal hemodynamic pattern with some phases that are changing during time, presence of episodes of fetal venous district hemodynamic alteration, generally considered as a sign of fetal compromise without abnormalities in the arterial district, and IUGR possible even at the beginning of the second trimester without alteration in the uteroplacental hemodynamics. You can see that we may have different causes of IUGR and chronic fetal oxygen deficiency. We described the fetal placental insufficiency, but now I'm going to show you the umbilical cord anomalies. This situation can produce, with very similar pathophysiological event, a reduction in fetal growth, alteration in fetal hemodynamic, and alteration in fetal biophysical profile. And this scenario is very important. The identification of this scenario is very important in order to avoid fetal organ system injuries and finally the fetal death. So we have to identify what's happening in the fetus. And we show you the result of this study, in which we find some cases, almost 7% of cases with very atypical IUGR with the situation that I'm going to show you with the atypical hemodynamic pattern. You can see this patient was referred to me for the morphological evaluation for the anomaly scan at 22 weeks of gestation. And the colleagues that referred to me, this patient was very concerned about the reduction in the fetal growth and the absence of the reduction in the amniotic fluid. And after an amnion infusion that I performed in order to see the fetus, I saw that there was no fetal abnormalities, and I was concentrating into the hemodynamics. You can see I was checking the umbilical arteries and the umbilical vein that appears normal. I was evaluating the fetal arterial district. Here you can see the aorta. And I was checking also the maternal side with the evaluation of the uterine perfusion that was completely normal in this case. I was checking also the fetal cerebral circulation that was normal again. And I was checking the venous district. Very surprisingly, I was evaluating this district with this evident alteration in the hemodynamics for example, in the ductus venosus. You can see here the normal waveform profile in healthy condition, and we can see here what I was detecting in this condition without any alteration in the arterial district of the fetus and in the uterine perfusion. I was checking also the inferior vena cava. Again, you can see here the reduction in the forward flow and very evident reverse flow during atrial contraction. So it was very strange for me, unexplicable what happened in this situation. And I went again to the evaluation to the umbilical cord, and you can see here I was checking another segment of the umbilical cord in this kind of entanglement, and I was seeing this very strange pulsation in the umbilical vein. And I was checking here in this segment of the umbilical cord, very atypical situation with the velocity in the umbilical vein that was 3 times higher than in the peak velocity in the umbilical artery. And I was looking again to the heart, and again you can see that in this situation we have a typical alteration in the hemodynamics, in the inflow, ventricular inflow hemodynamics that we found before in the early onset IUGR in the decompensation stage, with the reduction in the atrial contraction waveform profile. And we can see what was the causes, the hypercoiled umbilical cord. You can see here the final part very close to the abdominal insertion is without blood, because it's very is characterized with very high torsion. So in the conclusion, we have a different type of scenarios when we are evaluating fetus characterized with intrauterine growth restriction. We may have early onset IUGR, which is characterized by the typical cascade of hemodynamic events starting from placental functional and structural alterations through the fetal and the uterine hemodynamic alteration leading to intrauterine growth restriction and possibly to fetal injury and finally even to fetal intrauterine death. We may have the late onset IUGR. The hemodynamics of these scenarios is characterized essentially by the presence of brain sparing and by the absence of the typical progression of the fetal hemodynamics event that we can find in the early onset. This group, even if the hemodynamics events are late and generally less evident, may be characterized by possible fetal injuries and finally even fetal intrauterine death to the possible fetal hemodynamic failure. So it is important again to make the diagnosis of these scenarios. And as I showed you, we may have also another scenario that I call it atypical IUGR. In these scenarios, the IUGR are at hypoxic risk and showed an atypical hemodynamic pattern with variable and instable fetal hemodynamic alteration characterized by episodes of fetal venous district hemodynamic alteration that generally are considered as a sign of fetal compromise without abnormalities in general, without abnormalities in the arterial district and the normal flow in the uterine perfusion, so in the uterine arteries. Finally, when an IUGR is suspected and the hemodynamics evaluations show an atypical pattern, the studies of the umbilical cord for pathologies like true nodes and anomalous calling is recommended. And when IUGR is suspected, a multidisciplinary approach is mandatory and the case must be managed in the referral center. Thank you. Thank you for hosted me in this important meeting. And I don't know how is the organizing, what is the organizer the meeting, but I am ready for any question. Thank you again.